So the guy who's got his hands on the CTA images in addition to all the nuclear images. So John MAHMARIAN basically heads up our group on nuclear medicine and also on the CT scan. CT is the relatively new addition really to the heart and vascular center, and he's the guy who drives it. He's past president of the American Society of Nuclear Medicine.
Okay. Thanks very much, Alan. We have is the advancer here? All right. I have to get all organized here. So today I'm going to actually talk about nuclear cardiac imaging and see where it fits in terms of doing interventions. And the first thing I want to say is, there's a rationale for doing cardiac imaging from a nuclear point of view. First, identifying symptomatic patients with known or suspected disease who are unlikely to benefit from an interventional approach, but would still warrant medical therapy. And those would be low-risk patients with small perfusion defects or patients with normal myocardial perfusion scans, where you'd actually like to then identify patients in terms of preventing progression of disease and potentially regression. And also those higher risk patients who don't have ischemia, where really then it's more medical management. And also identifying, conversely, the high-risk patients who clearly do have ischemia and myocardial viability, where you really want to target aggressive anti-ischemic interventional and medical therapies. This is a typical myocardial perfusion scan. We look at the perfusion images, stress and rest. We also look at the gating in terms of the wall motion, and we can quantify perfusion abnormalities. And all this is done basically high diagnostic accuracy with this kind of technique. Now, if we look at using myocardial perfusion imaging as a gatekeeper to the cath lab, you can see there are many studies published over the years. Okay, as a gatekeeper to interventional cardiac procedures, you can see with a normal myocardial perfusion scan, you have a very low likelihood of having death or MI, whereas you have a 10-fold higher likelihood of having an event if the scan is abnormal. This is important because we've known over the years that the likelihood of having an abnormal myocardial perfusion scan has gone dramatically lower over the last 10 to 15 years. And so in many respects, most of the patients who have myocardial perfusion scans will have normal studies, and that will be a way of identifying those who do not need a invasive coronary angiogram. This is data from our laboratory several years ago, where we actually looked at acute chest pain patients who were relatively low to moderate risk. Many of them did have coronary disease, and you can see patients with a normal study had an extremely low event rate, okay? And those with an abnormal scan clearly had a much higher event rate, but the important point of this slide, as far as the gatekeeper in this particular study, you can see that only 3% of patients underwent cath who had a normal study, only less than 1% of the entire group got revascularized. So again, a gatekeeper. Even though myocardial perfusion imaging is a great way to identify low-risk patients, it does have a limited warranty in terms of event rates. And this is some data from our laboratory in over 1,100 patients followed for a decade, showing the interrelationship between calcium scoring and a normal myocardial perfusion scan. So you can see that in patients after about 3 years, even though they may have had a normal myocardial perfusion scan, if they had underlying atherosclerotic disease based on their calcium score, they still continue to have events. So now we really recommend in patients with normal perfusion scans who are intermediate risk, they should have a calcium score to identify whether they have atherosclerotic disease to better identify those who you can prevent them having an abnormal scan later down the line. Next slide. Next. Okay. Conversely, when you think about myocardial perfusion imaging, size does matter in terms of the amount of abnormality. So if you have a normal study, you have a very low event rate. If you have more than 15% of the left ventricle that's abnormal, you can see the event rates go up significantly. And that's when you look at total events or death and MI. Next slide. And when you look at ischemia, it's the same thing. As the ischemic burden goes above 10% of the myocardium, you see a much higher rate of cardiac events. Next slide. Okay, this has also been shown with PET imaging, and I think you can see in this PET registry that in patients who have normal myocardial perfusion scans, they have a very low event rate in terms of cardiac death or all-cause mortality, but as the perfusion defect size go up above 20%, the event rates increase significantly in both areas of cardiac death and all-cause mortality. Next slide. And in fact, you get a 34% increase in cardiac death for every 10% increase in ischemic myocardium. Next slide. Okay, this is some data from our study several years ago, the INSPIRE trial, in almost 800 clinically stable patients after myocardial infarction. This is looking at perfusion defect size and ischemic defect size. Next slide. showing that after a defect of about 20% or more than 10% ischemia on the right, that's where you see an exponential increase in event rates. And so that seems to be the hinge point, 20% or less being low risk or high risk, and 10% ischemia low risk or high risk above that example. Next slide. And in fact, we actually we did regression models looking at this. Next slide. So if you look at someone who had a 30% defect and it was all ischemic, you'd have a 25% event rate at 1 year. Next slide. Whereas if you had a 30% defect that was all scar, it would only be 11%. So you can actually use these data to kind of guide who really needs to have a interventional approach or not. Next slide. Okay. Ejection fraction is also important, and you can see that in patients with low ejection fractions, less than 45%. Next slide. You have an increase in event rates. Next slide. And that's irrespective of the size of the initial perfusion abnormality. So ejection fraction interplays here in terms of predicting overall outcome. Next slide. And this is also true when you look at patients with ejection fractions greater than 40% in terms of looking at regional wall motion. So patients without ischemia who have good ejection fractions and normal wall motion have the least event rates as compared to those who have both ischemia and abnormal wall motion, despite a preserved ejection fraction more than 45%. So all of these different parameters can be utilized, and we utilize them every day to identify these high and low risk patients. Next slide. Coming up importantly now is this whole idea of coronary flow reserve, and this we do with PET imaging, and this is becoming really a very interesting area of investigation, looking at microvascular dysfunction, and we know that as the coronary flow reserve goes down, event rates go up. Next slide. Next slide. And in fact, there's a very poor relationship between actually coronary flow reserve abnormalities and the extent of coronary disease, and that's actually important. Next slide, in this regard, because next slide, if you have a coronary flow reserve that's high and you have minimal extent CAD, you do very well. Next slide. But irrespective of the extent of CAD, whether it's low or high, if the coronary flow reserve is low, patients do poorly. Next slide. And in fact, next slide, if you look at patients with high CFRs, they do well irrespective of whether they get revascularized or don't get revascularized. Next slide. But if you look at patients with low CFRs, clearly those who don't get revascularized have a much higher event rate as compared to those who have PCI, and particularly those who undergo bypass surgery. Next slide. What's also important to remember is the gender difference. It appears that more women with non-obstructive disease have abnormal coronary flow reserve. And this could be your typical patient who comes in with chest pain, you do a cath on them, they have minimal disease, and yet they still may have significant underlying microvascular disease that needs to potentially be recognized and treated. Next slide. And in fact, this is most particularly true in women, that as the coronary flow reserve goes down, event rates go up. Next slide. Next slide. So as I said, this is an ongoing area of investigation which I think is really going to help us distinguish, particularly in these higher risk patients, who potentially could benefit from therapy versus no therapy. Next slide. So in conclusion about this particular aspect is that we know that with increasing risk, we see that with increasing jeopardized myocardium, abnormal coronary flow reserve, extent of coronary disease, the type of population you're looking at, whether it's an asymptomatic population versus those with known stable CAD or those post-MI, and clearly as the ejection fraction goes down. Next slide. Now, this is the 800-pound gorilla in the room. Next slide. It's the whole idea, next slide, of how do we optimize therapy in these patients who clearly have ischemia? Next slide. All right. So we do know that there are certain populations that do benefit from bypass surgery. Those with left main disease, those with triple vessel disease, where you have at least we have triple vessel disease and a low ejection fraction, and particularly also those with coronary disease, more than 70% stenosis in an LAD, as well as another vessel. Next slide. A class 2 indication clearly is in those with more than 70% disease in 2 vessels, where one is the LAD and where you have at least a 20% perfusion defect on a nuclear study, or where you just have isolated 70% stenosis of the LAD with ischemia. Next slide. Where we also know is that survival doesn't really improve in any of the other groups. And in fact, if you look at the multivariate analysis on the right, next slide, And particularly in the last 3 studies that have been done, there has been very little benefit shown with PCI in terms of improving mortality or preventing infarction for that matter versus medical therapy alone. It's all been with bypass procedures in the literature. Next slide. Okay, there are many studies showing with serial perfusion imaging that you can see changes in myocardial perfusion with different medical therapies and also things such as statin therapies. Next slide. This is with SPECT. This is with PET. So there's a lot of literature out there. Next slide. This is a case of mine. Next slide. Showing a patient with a rather large 26% quantified perfusion defect. Next slide. He had only on catheterization a very big septal perforator that was diffusely diseased. Next slide. And we treated this patient with nitrates and beta blockers, and the scan now is completely normal. So it can show you how you can monitor and modulate coronary flow reserve and be with medical therapy and get good results. Next slide. This is the INSPIRE trial. I already alluded to this. We looked at the prognostic value of myocardial perfusion imaging based on the defect size, low risk being less than 20%, intermediate risk 20%, but no ischemia. But importantly, we randomized people who had high amounts of ischemia and large defects to medical therapy versus revascularization, and then monitored them serially. Next slide. And what you'll see here is that overall, the total defect size in the randomized group went from 33% of the myocardium down to 16, a markedly reduction. Most of that was due to a reduction in ischemia with very little reduction in scar size. Next slide. And what you'll also see, next slide, is that the reduction in ischemia, both total defect size and ischemia, was no different between those who got revascularized, that was PCI, or bypass versus medical therapy alone. Next slide. And in fact, the number of patients who had a significant reduction, defined as more than a 9% decrease in defect size from serial study 1 to study 2, were the same. This is the variability, though, that you see. You can see when you look at medical therapy in terms of total defect size or ischemic defect size and revascularization in red, that there's a tremendous splay in terms of the amount of change that you can achieve with either of those kind of medical or revascularization therapies. Next slide. But what we did show is that over a year period, irrespective of the therapy that was given, medical therapy did just as well as revascularization. Next slide. And in fact, we expected a 25% event rate in this population based on their initial study results. Next slide. But we saw, but based on the second scan, we only expected a 7% event rate. And what we observed, next slide, was exactly that, a 7% event rate. Next slide. So we can actually define initial risk and also track subsequent risk based on the effects of therapy with serial SPECT imaging. Next slide. This is just an example of someone who was actually in INSPIRE randomized to interventional treatment, but ended up getting medical therapy because his targets weren't good. You can see that the patient had initially a 43%, almost entirely ischemic perfusion defect that went down to 8% with medical therapy. Next slide. The expected event rate based on the first study was 35%. The expected event rate on the second study based on the 8% defect size was 3%. Next slide. This patient did not have an event. Next slide. Thank you. Next. All right. There's another trial called the COURAGE study, which also looked at this in terms of serial imaging. And remember, COURAGE compared PCI versus medical therapy in patients with stable coronary artery disease. And patients had a pre-therapy SPECT study and then a post-therapy SPECT study at 6 to 18 months. Next slide. And what you'll see here is that there was a tremendous amount of variability in terms of the response, in terms of reduction in defect size, PCI plus medical therapy versus optimal medical therapy alone. Next slide. And although PCI and optimal medical therapy did better, still 20% of the patients in the optimal medical therapy study limb alone had a successful reduction in their total defect size based on variability assessment. Next slide. And what was important from this slide is showing that if you look at their second study, as the residual defect size went up, irrespective of whether they got revascularized or got medical therapy, the event rates went up. So the whole idea here is that if patients still have more than 10% ischemic myocardium, even after they've had revascularization or medical therapy, they're not going to do well. Next slide. I've already shown you the INSPIRE data. This is data from Dan Berman's study, again showing that around a 10 to 12% ischemic burden is where you're most likely to see a divergence where revascularization does better than medical therapy. Next slide. And I already showed you with INSPIRE, this was the same thing. Next slide. So finally, I just want to mention that there is an ongoing trial right now called the Ischemia study. It's looking at stable patients who have moderate to severe ischemia, who have a blinded CTA first, to be able to make sure they don't have left main disease or no coronary disease. And then if they have more than 10% ischemic myocardium or other criteria based on CMR or stress echo, they're being randomized either to intensive medical therapy versus intensive medical therapy plus revascularization. And this trial is going to follow patients for 4 years. The recruitment is about 2/3 finished. It'll be a very interesting paradigm to see then in patients with ischemia, what's the best way to treat them. Next slide. So in conclusion, physiology does matter. This is a case who has a patient has a moderate LAD lesion by CT and a small perfusion defect by physiology, which would indicate low risk. Next slide. And so the whole idea of myocardial perfusion imaging, again, to recap, is to identify patients with CAD unlikely to benefit from an interventional approach. Those would be low-risk patients with small ischemic burdens or higher-risk patients without ischemia. Next slide. Identify and triage high-risk patients with significant ischemia to proper interventional approaches or medical therapy. Assess initial risk and track risk based on serial imaging. Next slide. And finally, optimize risk stratification and management decisions based on these kind of parameters to predict patient outcome post-therapy. Thank you very much.
I know you got to go and interview people, but, so we've been talking a lot about fusion.
Yeah.
Post-processing fusion.
Yes.
You're going to have a PET CT scan.
Yeah. Now, okay, so the idea of fusion is really interesting. You know, we actually did this several years ago, even when we had a SPECT CT, okay? And the idea is to be able to overlay a CT image on top of a PET or SPECT image and be able to clearly identify which arteries are causing ischemia. So you better target revascularization. Now that's not the case in patients who have severe triple vessel disease. But in patients where you don't know, where you think that someone might, someone has, let's say, a 50 or 60% lesion on a CT scan, and then you see a perfusion abnormality on a myocardial perfusion scan, that might very nicely help identify which artery. Let's say you have 50% here and 60% there, and you're not sure which artery to dilate. That would help tremendously.
All right, I'm going to set you up here because you got a guy in the audience who started heart flow. He thinks this is all bull. And
yeah, right.
He's going to put you out of the game, and you're not even going to be looking at these.
Well, I mean, the whole idea of coronary flow reserve and looking at FFR are very different. And you know, there actually isn't there's actually a correlation, but not a great correlation between.
I'm going to get my microphone.
Okay, between coronary flow reserve and between FFR. Coronary flow reserve looks at the entirety of the vascular bed. It looks at the epicardial and microvasculature. FFR basically looks at stenosis. And it's not that I don't believe in FFR, because if you look at FAME 1 and FAME 2, for instance, I mean, it clearly showed that FFR was helpful in terms of targeting specific angioplasty procedures to a given patient. But I want to caution you a little bit on the results of FAME 1 and FAME 2, because when you look at overall death, there was no difference. When you look at prevention of myocardial infarction, there was no difference. And the only thing that was different in FAME was preventing revascularization in people who develop recurrent angina.
Right. So Chris Aaron's a vascular surgeon. They're all going to be working for vascular surgeons eventually. He's taken over the world. He started this company. You better tell everyone what FAME is, because I have no idea what that trial is.
Oh, FAME. Okay, so FAME was a trial that was put forth several years ago, where patients were randomized with coronary artery disease, and they went to the cath lab, and then they were randomized to either have an FFR determination of whether an artery needed to be revascularized, or just a visual objective look at it to see if a patient needed to be revascularized. And what was shown is that in the FFR-guided limb, there was a significant reduction in overall event rates as compared to simply just revascularizing patients based on anatomy alone. So FAME was probably one. It's kind of, I think FAME is kind of interesting because for 30 years, I've been doing perfusion imaging. And we have said for 30 years that physiology matters. And finally, now in the cath lab, FFAIM comes along, and now all of a sudden it's like reinventing the wheel. All of a sudden, physiology matters again, okay, because it was done in the cath lab. But again, the idea is this, that the extent of ischemic burden is what really drives serious, hard cardiac events such as death and MI. Soft events like the need for revascularization because of angina is really driven by people with lesser disease, such as single vessel Wright or single vessel Cirque. And in those patients, FFR can be helpful in terms of getting rid of angina, but nothing else.
You can't filibuster to get
There we go. Okay.
to the point that you don't get the question. So wait, don't
more?
Yeah, no, he's going to have a go at you. Chris is the president of HeartFlow, and he's going to give a lunchtime talk.
Okay.
So that's that disclosure. He thinks. I thought that was a picture of your tie, all that kind of red stuff that you put up
Isn't
there.
that
It doesn't
beautiful?
look like anything.
Well, you know what I love what I do? Because I see black and white all day on CT, and then I switch to color, which is really kind of nice.
All right, Chris.
So I think the difference between myocardial perfusion studies and FFR is that with FFR, you're actually looking at lesion-specific ischemia. In other words, correctable ischemia, because you've got a specific lesion and a specific artery, you can identify that with FFR. You can't really do that with perfusion imaging. So when you say, why does the COURAGE trial, for example, show no difference between medical and interventional therapy? Well, that's probably because half of the patients in the interventional arm didn't have lesion-specific ischemia, yet they got stented, and half the patients in the medical arm did have lesion-specific ischemia, were not identified, and were treated medically. So, of course, you're not going to have any difference in the treatment arms of the two groups. But I think in the future, the problem with FFR is nobody uses it. So It's been proved in all of the prospective trials very effectively. It's the standard of care. It's what everybody is supposed to use, but everyone in the cath lab uses visual image guidance of the angiogram. So they're not actually using FFR in the cath lab, but in the future, as that becomes available to actually have lesion-specific ischemia assessed, I think you are going to see a difference in the outcome arms.
Yeah, I agree with that, but I also agree that the issue with nuclear imaging is you look at the entire vascular bed, and there are many medical approaches to treating myocardial ischemia, as I've shown you. I mean, we can resolve myocardial ischemia very well with medical therapies where patients wouldn't necessarily have to have an intervention. And I think it's also important to recognize that when you look at all of the data over the years, coronary artery bypass surgery has been the only technique that has been shown to actually reduce mortality and prevent infarction in patients with extensive coronary artery disease.
The single greatest myth perpetuated on the American population is that it is the only thing that's been shown to make you live longer is an Alimad and LED bypass. You agree?
Well,
We can cut down on your angina.
That's right. But I mean, and again,
Where's that on the consent forms?
Well, I know. But I mean, no, that's actually true. But I mean, if you look at if you look at the guidelines and you look at the recommendations based on guidelines, I think there is enough data out there, and it's been based when I was just a fellow till now that bypass surgery as a technique for multivessel disease is the only technique that's actually been shown to reduce mortality.
Well, let's stop right on that high note. Thank you very much. Thanks for coming. Go ahead and interview. Yeah, appreciate it.